needs to be explained, and a few questions of applied anatomy, like application of anatomy into clinical scenarios. That also I have tried to include. So to start with, I must say a few key points to remember. Like anatomy is usually best evaluated with T1 and T2 sequences, whereas the pathologies are best evaluated with the fluid sensitive sequences like STIR or PD. And we need to develop a search pattern in MSK radiology. So I personally try to use two kinds of search pattern. The first search pattern is evaluation of the general anatomical structures, then to look for the sites showing increased signal in fluid sensitive sequences, and coming back to evaluation of those specific anatomical structures at those particular sites. Another search pattern, which is a more lengthy procedure, but almost foolproof procedure, is an inside out approach, looking for the osteology, then joints and articular surfaces, then looking at the ligaments and the tendons, and then the muscles, the overlying muscles and neurovascular structures, skin and subdermis. In MSK radiology, particularly, we need to be aware of a particular artifact, MR artifact, which is known as the magic angle effect, which in case of upper limb, it is seen particularly in evaluation of supraspinal tendon and TFCC, in which the tightly bound collagen molecules, which are at a particular 55 degrees angle with the magnetic field, tend to show increased signal in short T sequences like T1, PD, or GID sequences, tend to show increased signal, which is actually artifactual. We need to correlate them with the longer T sequences like T2 sequences. And another thing, we also, since in MSK radiology, the field of view is generally very small, so we need to take low SNR into account, and SNR, that is signal to noise ratio, which should be ideally kept at around 4 or 5. But if it is like SNR of 1, means the particular image is equally contributed by the signal and the noise, so that can lead to false interpretation. So we need to resort to a few techniques for improving SNR, which includes increasing the magnetic field strength from 1.5T to 3T if available, or increasing the number of excitations, like using a 90-degree flip angle. So there are few methods to improve SNR. We need to resort to them. So now coming to the proper quiz time. So here goes your first question. The moment this question will be seen on your screen, you can give your options, but I'll be reading out the question, and after 20 to 30 seconds, the poll will be over and I'll discuss that. So the first question is, which of the following spinal nerves never contribute to the brachial plexus? Is it A, C4, B, C8, C, T2, or D, none of the above?
The poll is live, sir. I'm ending the poll, sir.
Yes. Can I have the results of the poll? Like which option got the maximum votes?
Sure, sir. 53% of the attendees have answered C, sir.
53% have
Yes,
answered.
sir.
Well, the answer is in fact none of the above. Why? The question was, which of the following spinal nerves never contributes to the brachial plexus? The options were C4, C8, T2, and none of the above. So the answer is none of the above. I'll be explaining this in the subsequent slides. Now let us go through a bit of like how those nerve roots exit from the spinal cord. Now from the spinal cord, one dorsal root exits and one ventral root exits. They together join to form the particular nerve. Like if it is at the C2 level, then that is C2 spinal nerve. Then again that divides into the posterior rami and the anterior rami. Now the brachial plexus are formed by fusion of anterior rami of no, before that, there is a dorsal root ganglion which is seen in the dorsal root. This is of importance because any injury before this, that is known as like the avulsion from of this nerve rootlet from the spinal cord, that will be counted as preganglionic nerve injury, and any injury here after this dorsal root ganglion will be termed as a postganglionic nerve. Now, the brachial plexus is formed by these anterior or ventral rami of C5, C6, C7, C8, and T1 nerve roots. In few cases, it may include C4 nerve root when it is called as prefixed brachial plexus, or it can also include a T2 nerve root, in which case it is known as postfixed brachial plexus. Now, there is a difference. Like this is the roots of the brachial plexus. Those were the roots of the spinal nerves. So, injury or avulsion of the roots of the spinal nerves is a preganglionic injury, but injury to the roots of the brachial plexus, like these C5, C6, 7, 8, and T1 nerve roots, are in fact postganglionic nerve injuries. This we should be aware of. Now, the C5 and C6 nerve roots, they join to form the upper trunk. Then the C7 continues as the middle trunk. Then C8 and T1, the roots of the brachial plexus, they join to form the lower trunk. Now, these roots and trunks are at the level of the neck between two important anatomical structures, which I'll be showing subsequently, that is the scalenus anterior and the scalenus medius and posterior muscle. Now these trunks, each trunk, now we have got a mnemonic to remember, like roots, trunks, division, cords, and branches. Like radiology, toppers, drink cold beverages or beer, whichever you may find suitable. So roots, trunks, divisions, cords, and branches. Now these upper trunk, middle trunk, and lower trunk again divide into anterior and posterior divisions. The posterior divisions of each of the trunks, they join to form the cords of the brachial plexus, the posterior cord, and the anterior division of the upper trunk and the middle trunk, they unite to form the lateral cord of the brachial plexus, and the anterior cord of the lower trunk, that continues as the medial cord. Now these cords are named medial, posterior, and lateral in relation to the subclavian / axillary artery. In anatomic, if in purist anatomy textbooks, it is always written as axillary artery, but it is usually subclavian / axillary artery. You can very well see the very immediate and close relation of the cords of the brachial plexus with the subclavian artery, and these are named according to its relation with the subclavian artery. Now then it divides into various terminal branches, and before the terminal branches, individual segments can also give a few branches which are known as pre-terminal or collateral branches. As I was discussing, any injury of this nerve roots before this dorsal root ganglion will be termed as preganglionic injury, and any injury to this nerve roots which is beyond the dorsal root ganglion will be termed as the postganglionic injury. Now its relation with the for imaging of the brachial plexus, we need to remember these three pieces of anatomy. Then our life becomes a lot much easier while imaging brachial plexus. The three pieces of anatomy is this scalenus anterior muscle, scalenus posterior muscle, and the subclavian artery. The roots and the trunks will be between the scalenus anterior and scalenus medius muscle, whereas the cords of the brachial plexus will be related to the subclavian artery. So if we find out these normal anatomical structures, then it is very easy to find out the normal brachial plexus. We can practice it by seeing it in even all the MR of neck, MR of cervical spine cases. It will be visible to us. Now the second question, what is your diagnosis? A, rhabdomyosarcoma, B, lymphadenopathy, C, neurogenic tumor, and D, vascular tumor. So we can see altered signal intensity mass lesion here on the left side of neck. So what is your diagnosis?
The poll is live, sir.
Is it done?
Yes, sir. I'm ending the poll, sir.
Can I have the results?
Yes, 46% of the attendees have answered C, 26 A and B, sir. 26% A and 26% B, sir.
So there you go. Now you are getting it. So the correct answer is in fact C, neurogenic tumor. Isn't it really exciting that out of all the sequences, all the number of images, with a single image, looking at a single image, you are able to diagnose that it is a neurogenic tumor? How? I'll describe. Now we'll look at the normal anatomy on the normal side. So if like this is the trachea, this is the esophagus, and this is the longus colli muscles. Now, here is a muscle which is the scalenus anterior muscle, and here is the muscle which is known as the scalenus medius muscle. So just as I discussed right now, so where will the roots and trunks of the brachial plexus live? It is between these two muscles. So this is the plane where this roots and trunks of the brachial plexus will live. So coming to the affected side, what this lesion is doing, this lesion is causing displacement of this scalenus anterior muscle anteriorly and displacement of this scalenus medius and posterior complex posteriorly. And it is occupying the space between these two muscles. So what is the normal structure which resides between these two muscles here? It's the roots and trunks of the muscle. So this lesion must have been arising from the nerve roots or trunks. So it is a neurogenic tumor. Next question. Question 3, cervical rib pseudoarticulation with first rib is impinging on which component of the brachial plexus? Now here I could not show the cervical rib from in a single image. So here is the pseudoarticulation of the cervical rib with the first rib on the left side. The question is, it is impinging on which component of the brachial plexus?
Poll is live, sir. I'm ending the poll, sir.
Please. Can I get the results?
Yes, sir. 53% of the attendees have answered B, 20% B and C, sir. 20% B and 20% C.
So that's more like it. So most of you have answered it correctly. That is the cords. Now here you can see I discussed the two pieces of anatomy in the last slide, and the third piece of anatomy is here. As you can see, this pseudo articulation of the first rib And what is another structures that is visible in this slide here is the subclavian artery, which is seen here and then again here. So this whatever pseudo articulation that is compressing on the brachial plexus is closely related to the subclavian artery. So that means this is impinging on the cords of the brachial plexus. You can see increased signal in the subsequent nerve distally, that is due to nerve edema, mixed due to nerve edema and as well as Wallerian, some degree of Wallerian degeneration. Since the nerves are tightly bound by the perineurium, so they show abnormal signal along its whole length. So this is impinging on the cords. Next question. Question 4, identify the component of brachial plexus in image. Roots, trunks, cords, or division.
The poll is live, sir.
Is it done?
No, sir. We'll give them 10 more.
Okay.
I'm ending the poll, sir.
Yeah. Results?
Yes, sir. 68% of the attendees have answered C, sir.
Yeah, very good. So the number of correct answers, of course, percentage of correct answers keeps on increasing. So this is just, I used another plane, that is the sagittal plane, which is a very difficult plane to assess. Now, the cords is the correct answer. Now you can see these, what is this structure? This is the subclavian. And there are three relatively hyperintense structures, which is pointed by the arrow. So since it is related to the subclavian artery, so these are the cords of the brachial plexus. So three pieces of anatomy, scalenus anterior, medius, and subclavian artery, will help us a lot to identify and localize the abnormality within the brachial plexus. Question 5, identify the abnormality. A, pseudomeningocele. B, preganglionic brachial plexus injury. C, none are correct. D, both A and B are correct.
The poll is live, sir.
Yeah.
I'm ending the poll, sir.
Yeah. Results?
83% of the attendees have answered D, sir.
D.
Yes, sir. D. Last option.
Okay, that's the correct answer. Both A and B are correct. As I discussed, so since this is the structure which is known as the pseudomeningocele. This is a case of avulsion of the nerve root from the spinal cord, which results in accumulation of CSF within the neural foramen, which is known as the pseudomeningoceles. Pseudo, since it is not outlined by dura. Now, this pseudomeningocele usually lies and this as a result of nerve root avulsion, which is proximal to the dorsal root ganglion. Hence, it is also a preganglionic brachial plexus injury. Hence, D, both A and B are correct, is the correct answer. Now, coming to shoulder in the sixth question. Now, identify the structure. A, conoid ligament. B, trapezoid ligament. C, superior acromioclavicular ligament. D, inferior acromioclavicular ligament.
The poll is live, sir. Amending the poll, sir.
Yeah. Results?
The 35% of the attendees have answered A and C, 13% B, and 20% D, sir.
Okay. So what we are looking at here is the let us identify some normal anatomical structures. So here it is the coracoid process, and this is the clavicle. So this is a band of hypointimal structure which is extending from the coracoid process to the clavicle. So this is the coracoclavicular ligament. Now, coracoclavicular ligament has got two parts, one medially placed bundle, this medially placed bundle which goes towards the conoid tubercle of the clavicle, which is known as the conoid ligament, and one lateral placed band which is which goes and inserts into the undersurface of the undersurface of the clavicle in the which is known as the trapezoid ridge, that is known as the trapezoid ligament. This coracoclavicular ligament is the main stabilizer of the acromioclavicular joint. So the answer is trapezoid ligament, B. Coming to the next question, 7. Identify the structures. A. Coracobrachialis, whether it is B. Short head of biceps, C. Pectoralis minor, D. Pectoralis major.
The poll is live, sir. Amending the poll, sir.
Yeah, results.
Sir, 57% of the attendees have answered B, 42% A, sir.
Okay, so now let us review the anatomy here. So this is the again the coracoid process. Now it has got this is the apex of the coracoid process. It has got the lateral apex, a lateral part of the apex, and a medial part of the apex. So the structure which arises from the lateral part of the apex here is the short head of biceps. Then structure that the muscle that arises from this medial apex is the coracobrachialis muscle, and the other muscle which gets attached to the coracoid process is the pectoralis minor. So three structures attached with the coracoid process, like this is to the lateral lamina or lateral part of the apex, that the short head of biceps. This is the coracobrachialis, and with the body of the coracoid process, the pectoralis minor gets attached. So the correct answer is A, coracobrachialis. The next question. Question 8. Identify the structure. A, pectoralis major, B, subclavius, C, supraspinatus, or D, serratus anterior.
The poll is live, sir. Amending the poll, sir.
Yeah.
So 90% of the attendees have answered B, sir. 10% of the attendees have answered C.
Yes, that is correct. Most of the people have answered it correctly. The answer is subclavius. Now, subclavius is a muscle which lies on the undersurface of the clavicle, which arises from the first costochondral junction and gets inserted with the undersurface of the clavicle. Now, the main function of this subclavius muscle is depression of the clavicle and elevation of the first rib. So, how it is important? Because in case of clavicle fracture, so this acts as a cushion and which may prevent injury to the brachial plexus or the subclavian vessels. Now, another important variant anatomy we must keep in mind is another muscle if it goes just below the subclavius muscle from the first costochondral junction to the superior border of scapula. That is an accessory muscle which is known as the subclavius posticus. This roughly bisects this pad of fat, this axillary pad of fat, this will bisect and it will lie below the level of the subclavius muscle. So that is a subclavius posticus muscle. Answer to this is B, subclavius. So the next question, 9, all of the following insert onto the greater tuberosity of humerus except A, supraspinatus, B, infraspinatus, C, teres minor, and D, subscapularis.
The poll is live, sir. I'm ending the poll, sir.
Yeah.
So 88% of the attendees have answered D and 11% of the attendees have answered C.
Very good. In fact, subscapularis is the correct answer. So these are the 4 rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. All the 3 muscles insert onto the greater tuberosity of humerus, whereas the subscapularis, this arises anteriorly from the subscapular fossa and then goes towards the lesser tuberosity and inserts there. So the answer is subscapularis, which inserts onto the lesser tuberosity of humerus. Now, question 10, all the following structures contribute to form the axillary recess of the shoulder joint except now A, joint capsule, B, anterior band of IGHL, that is inferior glenohumeral ligament, C, posterior band of inferior glenohumeral ligament, and D, middle glenohumeral.
The poll is live, sir. I'm ending the poll, sir.
Yeah.
So 66% of the attendees have answered D, 11% C, and 22% B, sir.
Correct. The most of the persons have answered it correctly. The answer is middle glenohumeral ligament. Now, the axillary recess of the shoulder or the axillary pouch is formed predominantly by the joint capsule, which is reinforced anteriorly by the anterior band of the inferior glenohumeral ligament and posteriorly by the posterior band of inferior glenohumeral ligament. Hence, middle glenohumeral ligament is the answer. That does not contribute to form the axillary recess. Next question, 11. Adhesive capsulitis of shoulder presents as thickening and hypointensity at which of the following sites? A, rotator interval, B, axillary recess, C, none, D, both.
The poll is live, sir.
Yeah.
I'm ending the poll, sir.
Yeah, please.
So 50% of the attendees have answered D, 33% of the attendees have answered A, and 11% of the attendees have answered B.
Yes, most of the people have answered it correctly. The answer is both. Now, the adhesive capsulitis of shoulder presents as thickening and hypointensity at both axillary recess as well as rotator interval. And if you are giving gadolinium, there will be a faint enhancement of the soft tissue within the axillary recess and the rotator interval. Now, as you can see, this is the axillary recess which has got thickened. Now, the cutoff value of this thickness is around 1.3 centimeter. If it is more than 1.3 centimeter, taking both the surfaces, both the opposing surfaces of the axillary recess into account. Now, coming to the rotator interval, this is an important piece of anatomy. Now, you can see that there is presence of abnormal soft tissue and faint enhancement within the rotator interval. Now, I'll be discussing a few points about the rotator interval. Now, what is the rotator interval? Now, the rotator interval is the space between the coracoid process and the anterior and the superior border of the subscapularis. and the anterior border of the supraspinatus muscle. The coracohumeral ligament, the long head of biceps tendon, and the superior glenohumeral ligaments. These are the structures which are present within the rotator interval. So as we can see in this MR image, so this is the anterior border of the supraspinatus. Then this is the superior border of the subscapularis. So this is the rotator interval. So the long head of biceps, coracohumeral ligament, they form a part of this rotator interval. In adhesive capsulitis, there is presence of soft tissue. Now, if I can go back one slide, as you can see, all the structures of the rotator interval are kind of smudged and thickened, and there is loss of normal anatomy. So the long head of biceps tendon, which is an intracapsular tendon that gets trapped within this soft tissue and leads to pain on elevation of the shoulder. So there will be thickening of the axillary recess as well as rotator interval in adhesive capsulitis. Next question. Identify the abnormality. A is fracture of acromion, or is it os acromiale, or C, calcific tendinosis of supraspinatus, or D, degenerative changes.
The poll is live, sir. I'm ending the poll, sir.
Yeah.
So 100% of the attendees have answered B.
Remarkable. So the answer is correct, os acromiale. So this is, as you can see, this is an accessory ossification center of the acromion process, which is unfused with the rest of the acromion. So this may mimic a fracture of acromion or a calcific tendinosis or a large osteophyte, but this hypointense cortical outline and relatively very well-defined interface with rest of the acromion will help us diagnose this os acromion. 13. Identify the structure. A, suprascapular notch. B, spinoglenoid notch. C, angle of scapula, or is it D, glenoidal ring?
The poll is live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
63% of the attendees have answered B, sir, and 31% answered A.
Okay, so that's good. That's B is the correct answer. This is the spinoglenoid notch, and it is very normal to get confused with the suprascapular notch. So I'd be discussing a little bit about it. So the clue to identify the spinoglenoid notch is to look at this glenoid face. This is the glenoid face, this is the glenoid. Now, what is this structure that is coming out? This is the spine of the scapula. So this notch is present between the glenoid and the spine of scapula, and it is posterior in location. How do I know that this is posterior in location? So I see two bulk of muscle, that is, one is infraspinatus and one is your teres minor. So I know that I am posteriorly located in space. So spinoglenoid notch lies posterior and inferior to the suprascapular notch, so which is in fact a suprascapular notch is a depression along the superior border of the scapula. So, but it will be located a bit anterior and superior to the spinoglenoid notch. Similar structures, same structures like the suprascapular nerve and the circumflex scapular artery, they pass through both the notches, but it needs to be differentiated because any entrapment of these nerves by any paralabral cysts If it is going towards the suprascapular notch and compressing the suprascapular nerve, then both the supraspinatus and the infraspinatus muscles will show denervation edema or denervation atrophy. But if the compression by the paralabral cyst is at the level of spine glenoid notch, then the nerve branch to the supraspinatus muscle would have already taken off. So there will be sparing of the supraspinatus muscle from the denervation edema or atrophy, and only the infraspinatus muscle will be atrophied if the suprascapular nerve gets compressed at the spine glenoid notch. So that is the significance. Most of them have answered correctly. Answer is B, spinal glenoid notch. Coming to the next question, 14, Gutelier classification grade. A, whether it is grade 1, B, whether it is grade 2, C, whether it is grade 3, D, whether it is grade 4.
Poll is live, sir. I'm ending the poll, sir.
Yeah.
45% of the attendees have answered B, sir. 27% of the attendees have answered C, and 18% A, sir.
Most of the people, I'm very glad that most of the people have answered this correctly. So Gutelier classification is nothing but measure of the fatty atrophy of the rotator cuff muscles following rotator cuff tear. So there will be reduced in bulk and replacement of the bulk of the muscles with fat. So it is classically divided into 5 grades. Grade 0 is normal. Grade 1 is appearance of fatty streaks. Grade 2 is less than 50% of the muscle replaced by fat. Grade 3 is 50% of the muscle replaced by fat, and grade 4 is more than 50% showing fatty degeneration. So the previous question, we can see that supraspinatus muscle is occupying the supraspinous fossa, but it is occupied, but it is outlined by fat on all sides, and same can be said about the infraspinatus muscle. So it will be less than 50%, but more than fatty streaks. So it is a grade 2 Gutelier classification grade. Coming to next question, 15. Identify the site of fluid collection indicated by the arrow. A, glenohumeral joint. B, axillary recess. C, subdeltoid bursa. Or D, subacromial bursa.
Poll is live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
So 100% of the attendees have answered C.
Yeah, that is the correct answer. In fact, subdeltoid bursa and subacromial bursa, they are usually taken together as subacromial subdeltoid bursa. But since the arrow was to the subdeltoid bursa, so the answer will be C, subdeltoid bursa. Now, in case of tear of the supraspinatus tendon, this subdeltoid bursa or subacromial bursal fluid collection may communicate into the glenohumeral joint, causing glenohumeral joint traumatic fluid collections as well. Question 16, identify the structure. A, infraspinatus, B, supraspinatus, C, teres minor, and D, subscapularis.
The poll is live, sir.
Yeah.
I'm ending the poll, sir. So 84% of the attendees have answered C, and 15% of the attendees have answered A.
Okay, so this is again correct by done correct by most of the people. So the answer is C, teres minor. In this case, like the fluid was seeping between the infraspinatus and teres minor. Usually they lie very close to each other, separated by a very thin fat plane. But since fluid was traumatic fluid collection was accumulating, that like separated these two muscles. Otherwise, the way to identify or to distinguish between the infraspinatus and teres minor is to follow them to their insertion. The teres minor will insert below the equator of the like if this is if the head of the humerus will be taken as a globe, then the infraspinatus will insert above the equator of the globe and teres minor will insert below the equator of the globe. So the answer is teres minor. Now coming to the 17, arrow points to A, triangular space, B, triangular interval, C, quadrilateral space, and D or D is it axillary recess. Yeah.
I'm in the poll, sir.
Yeah.
So 100% of the attendees have answered C.
Great, great. So as correctly pointed out by all the attendees, now we are looking at a space which is posterior because we are seeing the spine of the scapula from the acromion. So we are looking at a space which is located at the posterior part of the shoulder with fat and few neurovascular structures at its center. So this is the quadrilateral space or quadrangular space. So which the sides of which are it is bounded medially by the lateral border of the long head of the triceps, laterally by the surgical neck of humerus, inferiorly by the superior border of the teres minor muscle, and superiorly by the inferior border of the this is the superior border of the teres major muscle and superiorly by the inferior border of the teres minor muscle. So this is the quadrilateral space. There are important structures which traverse through it is the axillary nerve and the circumflex scapular artery vessels. Now, along with that, we need to be aware of two more spaces. This is the medial triangular space, which carries the circumflex scapular artery, and the lateral triangular space, which is also called as the triangular interval, which carries the radial nerve and profunda brachii artery. Coming to next question, question 18, identify the structure. A, short head of biceps, B, long head of biceps, C, coracobrachialis, or is it D, deltoid?
The poll is live, sir.
Yeah.
I'm in the poll, sir.
Yeah.
So 100% of the attendees have answered B.
Very good. So this is the long head of biceps, which has got an intra-articular tendon arising from the superior glenoidal rim or superior glenoidal tubercle, and it courses along the bicipital groove under below the this is the deltoid muscle, and it traverses within the bicipital groove to the arm. So this is the long head of biceps. Now, question 19, which of these following structures blends with the subscapularis tendon? A, superior glenohumeral ligament, B, middle glenohumeral ligament, C, inferior glenohumeral ligament, or D, coracohumeral ligament?
The poll is live, sir. I'm in the poll, sir.
Yeah.
So 40% of the attendees have answered C, 25% B, 20% A, and 15% D, sir.
Okay. Now, a bit of anatomy about the different glenohumeral ligaments. As I already shown you, the superior glenohumeral ligament within the coracoid interval. Now, the answer is B, middle glenohumeral ligament. I have already shown you the superior glenohumeral ligament within the rotator interval and the inferior glenohumeral ligament in the forming the axillary recess. Now, the key to identify the middle glenohumeral ligament is that we have to search anterior to the anterior glenoid any structure which goes from the glenoid and gradually blends with the subscapularis tendon. So this is the subscapularis tendon, this is the anterior glenoidal margin. So there is a thin structure which is going, and in subsequent scans it is getting blended with the subscapularis tendon. So that's your middle glenohumeral ligament. So the answer is B, middle glenohumeral ligament. Question 20, which is of the following structures are not affected in subcoracoid impingement? A, subscapularis tendon, B, long head of biceps, C, middle GHL, or D, supraspinatus tendon?
The 4 is right, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
Sir, 36% of the attendees have answered B, 31% D, 15% A, and 15% C, sir.
Okay. But the answer is, in fact, D, supraspinatus tendon. Now let's discuss a few things about subcoracoid impingement related to anatomy. Now this is less common than the subacromial impingement, in which the supraspinatus tendon gets compressed between the acromion and the humeral head. Now, in subcoracoid impingement, in few persons, the coracoid process that is the usually the anterior landmark that extends more lateral than normal. So then it predisposes to subcoracoid impingement between this coracoid process and the head of humerus. So the structures which gets compressed between this structure, these two structures are the subscapularis tendon, which goes through this to join at the lesser tuberosity. Then the long head of biceps, since the insertion of the subscapularis forms the biceps anchor or biceps pulley, so that also might get compressed. And obviously the middle glenohumeral ligament, just now I told that it blends with the subscapularis tendon, so that is also liable to get compressed. So a little bit of anatomy to share about the subcoracoid impingement. Now, what happens in the subcoracoid impingement, as the distance between this coracoid process and the anterior surface of the head of the humerus, that gets reduced. The cutoff value we usually take as 6 millimeter. If it is less than 6 millimeter, then that is defined as subcoracoid impingement. And also the coracoid index. What is the coracoid index? The lateral most extent, how much far it is from the glenoidal face. So that vertical distance we have to measure. Normally it is within 8 mm. If it is more than 8 mm, then also it predisposes to subcoracoid impingement. So the answer here will be supraspinatus tendon, which gets compressed in subacromial impingement rather than in subcoracoid impingement. Next question, 21. Which of the following muscle inserts into a bone directly without a tendinous attachment? So we are coming to the elbow right now. So the choices are A, long head of triceps, B, medial head of triceps, C, lateral head of triceps, and or D, long head of biceps.
The 4 is right.
I'm ending the poll, sir.
Yeah.
So 54% people are saying it's option B.
B.
Yes, sir.
Yes, that is the correct answer. The correct answer is B, medial head of triceps. Now the triceps has three heads, one long head, medial head, and lateral head. So the long head and lateral head, they combine to form the triceps tendon, which inserts into the olecranon process. But the medial head of triceps, that comes down and attaches with the olecranon process without any tendinous attachment. So this is of clinical significance because if there is a tear of the triceps tendon, which is traversing only this tendon, but not this medial head of triceps, then it won't lead to that much of a muscle retraction. So, because this medial head will be attached to the olecranon process through its direct attachment. So, the answer is B, medial head of triceps. Now, 22, name the structure. A, annular ligament, B, lacertus fibrosus, or whether it is C, supinator, or D, pronator teres.
We are live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
So 80% people are saying it's option B.
Yeah, that's correct. That's correct. The answer is B, lacertus fibrosus, or it is also known as the bicipital aponeurosis. This is nothing but a condensation of fascia which holds the biceps tendon. This is the biceps tendon which holds the biceps tendon. So this is of clinical significance because if there is a tear of the biceps tendon, if tear is not involving this lacertus fibrosis or bicipital aponeurosis, then it won't lead to that much of a muscle retraction. So this is the bicipital aponeurosis which keeps the bicep tendon in its place. So answer is B, lacertus fibrosis. Now going to 23, identify the structure. A, anconeus, B, supinator, whether it is C, extensor carpi ulnaris, or D, extensor digiti minimi.
We are live, sir. I'm ending the poll, sir.
Yeah, please.
So 71% people are saying it's option B.
Yes.
Supinator.
Yes, that's correct. So most of the people have answered it correctly. So this is the supinator muscle. Now, as you can see, this is a muscle which is wrapping around the proximal radial sac, and it has got an attachment from the ulna. So this is a muscle in the proximal region of forearm, which is arising from the ulna and wrapping around the proximal shaft of radius to get inserted. And it has got another head which comes from the lateral epicondyle of humerus as well. So this is the supinator muscle. Question 24, identify the structure, whether it is A, anconeus, B, supinator, C, extensor carpi ulnaris, or D, extensor digiti minimi.
Live is, please live, sir.
Yes.
I'm ending the poll, sir.
Yeah.
So 100% people are saying it's option A, anconus.
That's great. Yes, the answer is A, anconeus. So now we are the arrow points to a structure which is a muscle which is between the radial head and the olecranon. So that is present on the lateral aspect. So this muscle is the anconeus. So this is this is not much of any clinical significance, but in case of lateral epicondylitis, this muscle may get abnormal signal as well, in addition to the common extensor tendons. So this is the anconeus muscle. Another muscle which we must keep in mind is its counterpart when it is present on the medial side. That is known as the anconeus epitrochlearis. The clinical significance of that muscle is that it may encroach upon the cubital tunnel, which is present medially, which carries the ulnar nerve. So that muscle may compress or may encroach upon the cubital tunnel and compress ulnar nerve, leading to ulnar neuritis or neuropathy. So this is anconeus. When this similar structure is present on the medial aspect, that is known as the anconeus epitrochlearis. Question 25, common extensor tendinitis is also called as A, golfer's elbow, B, tennis elbow, C, skier's thumb, or D, pin compression syndrome.
We are live, sir.
Yeah.
Ending the poll, sir.
Yeah.
So 81% people are saying it's option B. Tennis elbow.
I expected 100% answer, but this is usual. Even we get confused with which one is tennis elbow and which one is golfer's elbow. So the answer is tennis elbow. The common extensor tendinitis or lateral epicondylitis is also called as tennis elbow, whereas the less common medial epicondylar tendinitis is also called as the golfer's elbow. Here as we can see, there is presence of thickening and some abnormal stir hyperintense signal within the common extensor tendon, which is because of the common extensor tendinitis. And this is known as tennis elbow because particularly this leads to pain when you are grasping something very tightly with your palm and you are extending your forearm. Then it will lead to pain because of this inflammation at the common extensor tendon origin. This is tennis elbow. Now 26, identify the structure, whether it is A, Lister's tubercle, B, Steeder process, C, sublime tubercle, or D, conoid tubercle.
Alive, sir. I'm ending the poll now, sir.
Yeah.
So 63% people are saying it's option A.
Okay. Lister's tubercle. I'm afraid that is wrong because Lister's tubercle is seen in distal part of radius. Which bone we are looking at? This is the head of the radius. So this is ulna and this is the elbow joint. So we are anterior because here we can see a bit of the olecranon process. So this becomes the coronary process. Now this is the medial part. So the medial most part of the coronoid process of ulna is known as sublime tubercle. So this is answer is sublime tubercle. Lister's tubercle is seen in the distal part of the radius. Now, Steeder process is an accessory posterior tubercle of talus, and conoid tubercle, as I was discussing, is seen in the middle part of the clavicle. Now, the next question, the same image. Now, identify the structure, whether it is A, anterior bundle of ulnar collateral ligament, B, posterior bundle of ulnar collateral ligament, C, LUCL, that is lateral ulnar collateral ligament, or whether it is D, radial collateral.
We are live, sir. I'm ending the poll now, sir.
Yeah.
So people are confused between A, B, and C because 44% is for A, 33% is for B, and 22% is for C.
But most of them have got it correct. This is the answer is A, anterior bundle of the ulnar collateral ligament. Now we are looking at something which is attached to the sublime tubercle with a very sharp attachment, and then it is going up and it is getting a fuzzy kind of attachment at the medial or the common flexor tendon origin. So this is the anterior bundle of the ulnar collateral ligament. So ulnar collateral ligament has got a posterior bundle as well, which is usually evaluated in or best seen on axial images forming the floor of the cubital tunnel. So this is the anterior bundle of the UCL. Now an important sign is seen here in case of tear, that is known as the T sign, because this its insertion with the sublime tubercle is very sharp, and in case of tear, fluid will seep into it and it will lead to a bright signal here. So it will lead to a bright signal as the horizontal part of T and dark uh, signal of this ligament, or you can take this kind of fluid collection as the vertical segment of that T. So this T sign is seen in anterior bundle of UCL rupture. Next questions, 28. Which of the following nerves can get compressed at the arcade of Rose? Whether it is A, median nerve, B, radial nerve, C, ulnar nerve, or D, posterior interosseous nerve.
Yeah, live, sir. I'm ending the poll now, sir.
Yeah.
So 44% people are saying it's option B, posterior interest.
Yes. Yes, that's the correct answer. D, posterior interosseous nerve. Now, the arcade of Froese is a facial tunnel or fibrofacial canal, which is seen between the two heads of the supinator muscle. Now, this is the radial nerve between this muscle is the brachioradialis and this is the supinator. So, the radial nerve gives one deep branch which is known as the posterior interosseous nerve, which goes between the two heads of the supinator muscle, and this can get compressed here. Uh, this structure is known as the arcade of Rose, which compresses this posterior interosseous nerve, which can compress this posterior interosseous nerve, leading to pin syndrome. This the typical feature of this posterior interosseous nerve is it is a pure motor nerve. So this compression neuropathy will not cause any pain in the, rather it will present as weakness of the wrist extension. So this is the posterior interosseous nerve which gets compressed between the two heads of the supinator at the arcade of Rose. Now 29, identify the structure. A, Osborn's ligament, B, posterior bundle of UCL, C, lateral ulnar collateral ligament, or is it D, radial collateral ligament?
Yeah, live, sir.
Yeah.
I'm ending the poll now, sir.
Yeah.
So 80% people are saying it's option B, posterior bundle of UCL.
Yes, that is what I have already discussed. The posterior bundle of UCL is better seen on axial image, and it forms the floor of the cubital tunnel. So this is the cubital tunnel which is carrying the ulnar nerve, and this is the uh, posterior bundle of UCL forming its floor. So correct answer is B, posterior bundle of UCL. Now, question 30, identify the structure. A, Osborn's ligament, B, Lacertus fibrosus, C, UCL, or D, deep fascia. Deep fascia.
We are live, sir.
Yeah.
Ending the poll, sir.
Yeah.
So 71% are saying it's option A,
Yes,
Osborne's ligament.
that's correct. A, Osborne's ligament. So the arrow points to the roof of the cubital tunnel. We have already discussed the floor of the cubital tunnel. The roof of the cubital tunnel is formed by condensation of fascia, which is known as the Osborne's ligament, and the cubital tunnel houses the ulnar nerve. Here we can see the accessory structure that I was discussing few slides ago. This is known as the enconeus epitrochlearis, which is seen on the medial aspect, and it is impinging on the cubital tunnel. So correct answer is A, Osborne's ligament. Now 31, the arrow points to A, pseudodefect of capitellum, B, osteochondral defect, C, fracture of capitellum, or D, none of the above.
We are live, sir.
Yeah.
Ending the poll, sir.
Yeah.
So 71% people, 75% people are saying it's option A.
Yes, that's correct. This is the pseudo defect of capitellum. So how to differentiate it from an osteochondral defect or fracture of capitellum? The radiocapitellar joint is predominantly an anterior part of the elbow joint. Now here we can see where we are located at the space, because we are looking almost whole of the olecranon process as a single structure. So that means we are far posterior. So the pseudo defect of the capitellum is usually seen on the posterior non-articular surface of the capitellum, which can mimic an osteochondral defect or fracture of capitellum, but again it will be outlined by a thin hypointense preserved cortical outline. So the answer is pseudo defect of capitellum. Now the 32, tendon of which muscle inserts here? A, triceps brachii, B, pronator teres, C, biceps brachii, or D, brachialis.
We are live, sir.
Yeah.
Ending the poll, sir.
Yes.
So people are confused between option C and option D.
Mm-hmm.
It's 50-50%.
Okay, but there should be no such confusion if you look at the relevant anatomy. Now, biceps brachii inserts into the radial tuberosity, brachialis inserts into the ulnar tuberosity. So, which bone we are looking at here? Because this is the olecranon process, here the triceps are getting attached. So, we are looking at the ulna, and there is a tuberosity here. So this muscle is coming anterior to the elbow joint and joining and inserting into the ulnar tuberosity. So this is the answer. Correct answer is D, brachialis. Now 33, identify the structure. A, lateral ulnar collateral ligament, B, annular ligament, C, radial collateral ligament, or is it D, ulnar collateral ligament?
We are live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
So 100% people are saying it's option B. It's annular ligament.
Correct. So this is the annular ligament. So this there is a ligament which wraps all around the radial head in forming the proximal radioulnar joint. That is known as the annular ligament. We can see the cortical outline of the radial head and the articular cartilage, and then another hypointense structure which surrounds the radial head. This is the annular ligament. Correct. Now, next question, identify the structure. A, lateral ulnar collateral ligament, B, annular ligament, C, radial collateral ligament, or D, ulnar collateral ligament. This structure.
Ending the poll, sir.
Yeah.
So it's 60% people are saying it's option C, radial collateral ligament.
Okay. Now, here we are looking at the lateral part of the elbow. Now, this is the head of the radius. Now, the annular ligament will be wrapping around the head of the radius, so that is not the answer. Now, the radial collateral ligament is usually blends with the common extensor tendon origin. So it is very difficult to differentiate from the radial collateral ligament from the common extensor tendon origin. Now, here is a ligament which comes from the common extensor tendon origin, wraps around the head of the radial head and goes obliquely and downwards, and it gets inserted into a structure in the ulna, which is known as the supinator crest. So since it has got an ulnar attachment, but it is laterally placed, so this is known as lateral ulnar collateral ligament. This is a very important structure which keeps the radial head in its place and prevents its subluxation or instability, rotatory instability. Tear of this can lead to a condition which is known as the posterolateral rotatory instability of elbow, or PLRI of elbow. So this is the lateral ulnar collateral ligament. So answer is A. The next question, 35, identify the structure. A, polycranial process, B, coronary process, C, capitulum, D, trochlea.
We are live, sir.
Yeah.
Ending the poll, sir. So it's 100% people are saying it's option B.
Yes, that is what I expected. So it is the coronary process. This is in fact was a full toss question, which needed to be hit for a boundary. The point behind putting this slide is actually this one. This is an associated finding. You can see that there is a defect in the cortical outline of the olecranon process over here, which is hyperintense. So this is known as the pseudo loose body. So this is the coronary process, this is the olecranon process, and in between there is a gap in the cortical outline, so which is basically a normal structure because the cartilage that outlines the olecranon process uh, that carries a small small structure which actually forms as a junction between the two cartilaginous structure that is composed of two cartilaginous parts. This is known as the pseudo loose body. So along with pseudo defect of the capitulum, pseudo loose body, and another structure is plica, that is synovial plica, which is a meniscus-like structure, which usually lies at the radiocapitular joint, lateral part of the radiocapitular joint. So these three structures are normal variations which can simulate a tear or a fracture or a osteochondral defect. So answer is coronary process. Now 36, identify the structure, whether it is A, Lister's tubercle, B, Steeder process, sublime tubercle, D, coronary tubercle. Same options as the previous question.
We are live, sir. I'm ending the poll, sir.
Yes.
So 100% people are saying it's option A, Lister's tubercle.
That is correct. So I had already told that Lister's tubercle is bony prominence at the dorsal aspect of distal part of radius. This is the Lister's tubercle. It has got an anatomical significance in dividing the extensor tendons of the wrist, which we will be discussing subsequently. Now 37, Lister's tubercle separates which extensor compartment tendons? A, 1 and 2, B, 2 and 3, C, 3 and 4, or is it D, 4 and 5?
We are live, sir. I'm ending the poll, sir. So 80% people are saying it's option B, 2 and 3.
Correct. That is option B, 2 and 3. Now, discussing a few things about the common six extensor compartments of the wrist. Now, this is the listus tubercle. This is the radial side. This is the ulnar side. So this is it's the bony prominence, the extensor tendon. The like this extensor tendon compartment 2 from the 3. Now the 6 tendon compartments that that is numbered from the radial to the ulnar side. The first compartment carries 2 tendons, that is extensor pollicis brevis and abductor pollicis longus. The second compartment carries extensor carpi radialis and brevis. The third compartment carries the extensor pollicis longus. Then the fourth compartment carries the extensor indicis and the extensor digitorum tendons. The fifth compartment carries the extensor digiti minimi, and the sixth compartment, which is present within the groove for the extensor carpi ulnaris within the ulna, that carries the ECU tendon. So there is a like I remember it, the number of tendons in the form of a telephone number, that is 221 211. So from lateral to medial. So the listus tubercle divides the second and third compartment tendons. Now 38, identify the odd one out. A, flexor carpi radialis, B, carpi ulnaris, C, palmaris longus, D, flexor pollicis longus.
Your life, sir.
Yeah.
Ending the poll, sir.
Yeah.
So people are voting for option C. It's 57%.
Okay. So what is common between these like four? These are all flexor compartment tendons. So in flexor, how do we divide the flexor compartment tendons? As tendons which go beneath the flexor retinaculum or within the flexor retinaculum, and tendons which go outside the flexor retinaculum. Now, if we can revise that the tendons which go outside the flexor retinaculum are flexor carpi radialis, flexor carpi ulnaris, and a vestigial tendon which may occasionally be seen in few individuals, that is palmaris longus. Flexor pollicis longus is a tendon which goes inside the flexor retinaculum. So here you can see flexor carpi radialis, this is flexor carpi ulnaris, and this patient does not have the palmaris longus. So these three tendons, they go outside the flexor retinaculum, they travel outside the flexor retinaculum, and flexor pollicis longus, and flexor digitorum superficialis tendons, and profundus tendons, four of them, they for each of them, they travel inside the flexor retinaculum along with the medial nerve. So the odd one out will be flexor pollicis longus, which traverses inside the flexor retinaculum. Now 39, identify the structure. A, pronator quadratus muscle, B, pronator teres, C, flexor digitorum profundus, or is it D, flexor digitorum superficialis?
Your life, sir. I'm ending the poll now, sir. So people are confused between option A and option B. It's 50-50%.
Okay. So as you can see, this is the distal part of the radius and distal part of ulna. So and there is a boat-shaped muscle which is between the distal part of the ulna and radius. This is the pronator quadratus muscle. So this muscle has got significance, like it is a pronator, and in cases of the in cases of fractures of the distal radius and ulna, on the radiographs, on lateral radiographs, we can see a displacement of fat pad, which is the pronator fat pad. This bright signal intensity is known as the pronator fat band. So this will get displaced because of hematoma, intramuscular hematoma, or direct bony displacement. So this is the pronator quadratus muscle between the distal part of the ulna and the distal part of the radius. Now 5 more questions. 40. Identify the carpal bone. A. Trapezium, B. Capitates, C. Scaphoid, and D. Lunate.
We are live, sir.
Yeah.
I'm ending the poll, sir.
Yes. Yes.
So it's 75% people are saying it's option B.
B.
B, it's capitate.
Great. That's great. Now, from by just knowing the anatomy, we can know which bone is it. Out of there are 8 carpal bones. From a single image, you can tell which bone is it. How? Because this is the anatomic landmark. So this is the hook of the hamate. So the bone that is next to it is the capitate. So this is the capitate bone. Now 41, identify the structure between the first and second extensor compartment of wrist, denoted by the arrow. Whether is it A, ulnar nerve, whether it is B, superficial branch of radial nerve, or is it C, median nerve, or is it D, posterior interosseous nerve?
We are live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
So 100% people are saying it's option B, superficial BR of radial nerve.
Yes, this is the superficial branch of radial nerve which accompanies the cephalic vein between the first and the second extensor compartment of wrist. Correct. This is the superficial branch of radial nerve. Now, this is 42. Which of the following is a content of Guyon's canal? A. Median nerve, B. Radial nerve, C. Ulnar nerve, or D. Posterior interosseous nerve?
We are live, sir.
Yeah.
I'm ending the poll, sir.
Yeah.
The 100% people are saying it's ulnar nerve.
Correct. So the Guyon's canal is at the level of the hook of the hamate that carries the ulnar nerve and ulnar artery and vein, and the floor of which is an extension of the flexular retinaculum, which is attached to the hook of the hamate. So this is the Guyon's canal, and it carries the ulnar nerve. Question 43, identify the structure, whether it is A, fovea, B, sigmoid notch, C, ulnar styloid process, D, radial styloid process.
We are live, sir.
Yeah.
Ending the poll, sir.
Yeah.
So 75% people are saying it's option B, sigmoid notch.
Correct. So the answer is sigmoid notch. This is the radial styloid process. This is the ulnar styloid process. This depression near the ulnar styloid process on the medial side, that this is known as the fovea, and this articular surface of the distal radioulnar joint, which is present on the radial surface, is known as the sigmoid notch. So this is sigmoid notch. Now question 44. Which of the following does not contribute to the TFCC? A. Flexor carpi ulnaris, B. Ulnar collateral ligament, C. Triangular ligament, or D. Extensor carpi ulnaris.
We are live, sir.
Yeah.
Ending poll, sir. So 71% people are saying it's option D, extensor carpi ulnaris.
Okay, but I'm afraid the answer is A, flexor carpi ulnaris. Extensor carpi ulnaris, although does not contribute to the TFCC, but it is like an external stabilizer of the TFCC. I'll be discussing. So the answer is flexor carpi ulnaris. So now just discussing a bit of TFCC anatomy. Now this is a beautiful schematic diagram which will explain you the TFCC. So the TFCC is triangular fibrocartilage complex. So it is composed of many components. The predominant component is this disc proper, or which is known as the articular disc, which arises from the articular cartilage at the radial, at the distal medial most corner of the radius, and this extends medially where it gets divided into two components, two triangular ligaments. One is its uh, upper lamina that inserts into the fovea, and another that goes lower lamina, which inserts into the lower lamina of the triangular ligament, which inserts onto the styloid process. Now, this is also this is at the mid sagittal plane. While we go volar or dorsal, it will be reinforced by the uh, dorsal radioulnar ligament and volar radioulnar ligaments. The other components are ulnocarpal ligaments, particularly the ulnolunate and the ulnotriquetral ligament, and another structure which is known as the meniscus homologue, which looks like the meniscus, and it is reinforced by this ulnar collateral ligament and the tendon seat of the extensor carpi ulnaris. So this is the complete TFCC. Now coming to the last question. So identify the component of TFCC indicated by the arrow. A, triangular ligament, B, meniscus homologue, C, articular disc proper, or is it D, ECU tendon?
Realize.
Yeah.
I'm ending the poll, sir. So 81% people are saying it's option B.
Yes,
Meniscus.
correct.
Yeah.
This is the meniscus homologue. So now we can see the TFCC as just we discussed with that schematic diagram. So this will be the like articular disc proper, and which will insert onto the styloid process through the lower lamina of the triangular ligament, and the upper lamina of the triangular ligament will go and insert into the fovea ulnaris. In between these two, there will be a hyperintense structure which is known as the ligamentum subcruentum. uh, this should not be confused with tear, and subsequently this is the meniscus homologue and reinforced by the extensor carpi ulnaris. Uh, Now the dorsal radioulnar ligament and the volar radioulnar ligament we can find out on scrolling from dorsal surface to the volar surface. So this the correct answer is meniscus homologue. Thank you. So this completes all the 45 questions.
Thank you, sir, for taking us through the wonderful quiz and also giving us short tidbits of anatomy in between during the questions, sir. Thank you for your revision and your quiz session for today, sir.
Welcome, ma'am.
Ma'am, we have received a question, ma'am. I have posted it in chat.
Yes. Sir, they're asking if you could kindly explain the TFCC components on the MRI images, sir, if it's available.
Okay. So, so this image, like this is the MR image. Now the TFCC, this will be the disc proper, which will arise from the articular disc over this radial corner. So that will arise from this articular disc and it will go medially, where before inserting, it will get divided into two lamina or two lamina of the triangular ligaments. One is your lower lamina, which will go and insert into the ulnar styloid process, and another will go and insert into the fovea. So that is the upper lamina. And there will be, this is the meniscus homolog, and that will be reinforced laterally here by the ulnar collateral ligament and tendon sheath of the extensor carpi ulnaris tendon. Now the other component like the ulnocarpal ligaments and the radio ulnar ligament. The radio ulnar ligaments are two in number. One is dorsal and another is dorsal. Another is volar. So those will be, we can only see if we scroll through the images, like because they will be the dorsal radio ulnar ligament will just be dorsal to the articular disc proper, and the volar radio ulnar ligament will be volar to the articular disc proper at this level. But they cannot be seen in only one image. These are all the components of the TFCC.
Are there any more questions? I haven't received any other.
Ma'am, only one question, ma'am.